But what I'm going to do is now, I'm going to go to, got Sean and Elaine I want to talk to. I'm going to get into trouble for this, but call me old-fashioned. We're going to go ladies first. So Elaine, I'm going to come to you. How are you, Elaine? You okay?
Yeah, I'm good, thank you. Yep. You?
I know you've had a busy day. You warned me earlier. You might be running late, so thank you for your efforts. Thanks for getting to us. And indeed, thanks. I think you've been coming to us. You were there right from the first get-go, 25th of June.
Part of my Wednesdays. Wednesday evenings aren't the same without you guys. So you know that's
Exactly.
that's where we're at now. Yeah.
Yeah. So no, that's great. We do appreciate you joining us, mate. Pretty much every week. I haven't kept register, and I don't think you've met. If I had done, I don't think human crosses alongside your name. Yeah. So I suppose the first question I'll ask you, I want to come on to ask you a little bit about the scanners and so forth, and a little bit about your journey. But as I've mentioned there, you've been with us pretty much every week. Have you enjoyed it?
I have actually. I found it incredibly useful, and as well as it's nice to see other people. Yeah, no, I've really enjoyed feeling that I'm keeping the momentum going, because I think I mentioned to you I'm actually learning it. I feel like at the beginning, but seeing as I only really picked up a scanner earlier this year, when I look back, I feel like I have come a long way, but I know I've got so much far to go. And trying to do this, which feels like through most of lockdown, a self-taught thing really, because the clinic time was non-existent for a while, and I have the sort of the lack of mentor as a problem as well. So yeah, so this was a real anchor point, every week, every fortnight. Yeah, really, really helpful. Thank you.
Brilliant. Great. Well, I'm good. I'm pleased. I'm pleased to hear. And it was actually yourself, we talked earlier, didn't we? And in between us, we came up with that buddy idea, didn't we?
Yeah.
If people like the idea, I'm taking the credit for it. If they're not so sure, it's your idea, okay?
Okay.
So, okay. Right. So tell us a little bit, you touched on it a little bit there, but tell us a little bit about your experience as well, how long you've been scanning.
So unlike most people here, I'm not a podiatrist at all. I'm actually an osteopath. And I first came across scanning. I went to a sort of introduction taster day, CPD day, a couple of years ago, and I saw it and I went, oh wow, damn it, this is something I need to learn how to do. It's one of the things once I've seen it, I couldn't unsee it, and I kind of thought, yeah, this is very cool. I need to know more. And knowing that it's going to be such a commitment with time and finance to get to that point, it took me another couple of years before I actually signed up to a course. So I've so far done a weekend introduction last November, which was a prerequisite to the scanning course I'm currently doing at the moment, which started in January. And yeah, this year wasn't a great year to learn a workplace practical based skill at all. So it's been a bit sort of stunted. It's been sort of fits and starts. I've had a lot of time in lockdown where I've managed to really get to grips with the physics. I've had to relearn my anatomy all over again, which was probably not a bad thing. And it's now really the trying to get the clinic practice and scanning people really, which is where I'm at. As I said to you, I at the time I bought the X3, I thought that's expensive enough for me starting this, and it'll probably do me. I want to make sure it's not going to go obsolete. I'm not a techie person. I don't want to do anything apart from switch it on for the next few years. And then I spoke to you, as I said, 7 months later, I said to you, actually, I can see the difference now. I think I need to upgrade. So I'm quite amazed that I could see the difference. Before it was just 250 shades of grey, whereas now I'm starting to think I can see different things. And the one thing actually, Zoe, so you've got these two machines on trial. One thing that one of my tutors said to me right at the beginning was, get absolute the best machine that you can afford to buy. And I was like, yeah, whatever, of course, you're going to say that. It's easy for you to say these things are a lot of money. But just getting used to doing it, over the last few months, as I said, Steve, 7 months later, I kind of said to him, I need to upgrade. I need to upgrade it now, whilst, I'd use the benefit of the bounce back loans, to help me get going. But I thought if I don't do it now, I might not have the opportunity opportunity or the incentive in a year's time. So, you know, whilst you're still umming and ahhing it, I agree, you know, get the best that you can afford to buy, because it does make a difference.
It's an interesting one, because I mean, I sit in on other webinars and I listen to a lot of the experts, far more experts than I'll ever dream to be. And people talk about this kind of making it future-proof, getting a scanner that's future-proof. But it's a bit contradictory in a way, because at the same time, get a scanner, get scanning. Because would you agree, without a scanner, you wouldn't be as far down the road as you are now? That sounds like a loaded question to anyone.
Absolutely, yeah. I mean, but I don't think you can do it. It's such an intensive new skill, both in terms of being able to visualize it and getting the hand-eye coordination. I think that even if you were in a clinic or a hospital where you had access to it every day, I still don't think I still think you need your own. I still think you need your own to spend the time where you haven't got someone looking over your shoulder, where, you know, you haven't got, you know, a lot of patients to see. You could just get in and just, you know, just play with it and then feel comfortable with it, because there's a lot of buttons and knobs on these things. I haven't got a clue what half of them do, but I know the most important ones.
No.
And it takes a while, I think, to get the most out of them.
Yeah, it does. Yeah, no, that's very true. I'm stealing some of it, but you know, it's a bit like learning to play guitar. If you've only got access to that guitar once a week, you know, unless you've got hidden talents, unless you're the next bonehead out there, then it's going to take a long time to learn. So you know, that's really interesting. And there is this kind of, you know, yin and yang of making it future proof, but or just get what you can to get scanning, and you've got to weigh that up. And I think buy the best scanner you can, but at the same time, you know.
I'd just say, Steve.
Scanning. Sorry, Adrian. Yeah, sure.
Yeah, I mean, no scanner is really future proof. I mean, if you look at the NHS and their scanners, I mean, their guidelines are that you should, you know, only have your scanner for 5 to 7 years, and then you need to be chopping and, you know, changing it, because they do degrade, and they, you know, things do happen, and, you know, the image quality gets better. So you've got to weigh up what you want to do, whether you want to spend an absolute fortune on a machine that potentially you might need to change anyway in 5 to 6 years, or get a cheaper machine and just upgrade, you know, at the time, and then, you know, you're in a better position later down to upgrade if you want to. So you do have to be careful, because I mean, they all have shelf lives. Your probes will have shelf lives. Your scanner will have a shelf life. Yeah. So you do need to be careful with what amount of money you want to spend. If you've got loads of money to spend, then obviously you can do that. And if you want to add the 3D on and all those little singing and dancing things on there, obviously that takes the price up. But for what you want to do and get going, there's no need to spend absolute fortunes on a scanner. It really isn't.
Okay, brilliant. Thank you.
I don't think it should. I'm sorry.
No, go for it, Abid.
I don't think you should let that that thought hold you back at all. Don't even keep it in your head. You know, it's like any purchase you make. You know, everything grows old and goes out of date. Whatever you buy, whether it's an iPhone, whether it's a car, whether it's a battery, you know, everything has that shelf life. I wouldn't say, you know, spend what's comfortable and just get going. You know, everything else will sort itself out in its own time. You know, things will advance, things will develop. Sure, it will. Yeah. You know, but you know, any ultrasound is going to last longer than you need it. And you know, at the end of the day, even if you buy the latest up-to-date thing today, in a couple of days or in a year or so, there will be something to supersede it. If you look at ultrasound scanners now, I mean, the latest models are iPhone size. These gadgets coming out now with a little probe and stuff. You know, it's getting cheaper and cheaper and more affordable. So that changes all the time. At the end of the day, you've got to start your journey, and the sooner you get your hands on that ultrasound machine, the sooner you get going. So you know, don't break the bank. At the same time, don't be stingy with it. Spend that bit that you've got, and you know, there's always trade-ins and all the sorts of other things to do. But your scanner is going to last you long enough for you to get going. I just reckon you just gotta go. You know, put everything aside, forget about it. If you've got a bit of money, go for it and just get going, no matter what you can.
I think I was only reading yesterday that they said if you're going to spend the money invested in kit or education, then invested in the education. And
absolutely, and with this, it's the kit goes with the education hand in hand. So at some point, you got to just
No. What I mean is you've got to get the kit, obviously, but you know, if there's a compromise between the two, then get it on the training, spend it on the training first.
But is the training as valuable if you haven't got a machine to practice on?
No. I said that. Yeah, you know, you need a machine.
I think what Martin's saying is get a scanner, get any scanner.
But don't blow it all on the scanner. Just make sure you
don't think about getting the next one, and if you've got time, if you've got invest in the training. I think.
Don't think like Nike said. Just do it.
Brilliant. So thanks, guys. Great. So Elaine, back to you. Thanks ever so much. You've got a good little conversation going there. I mean, you know, as you say, you invested last year. It's in a difficult year, not a great time to be learning a new skill, as you say. You've done brilliantly to the point where you want to upgrade your scanner. So I think that's great. And I think that's all kudos and credit to yourself. And as I say, you know, not one size fits all. So that's brilliant. So we've got a good little conversation going there around that. So thank you, Elaine. But just a couple more questions for Elaine. So how much scanning would you say you do typically in a day, in a normal clinic day?
At the moment, I don't think I'm doing anywhere near enough, but I think that's purely because since lockdown, really, because after lockdown opened, the clinic where I'm at, we've had to all drop our days attendance to maximise number of people in the building at any one time and so on. So essentially, I used to work five days a week. I'm now doing 3, but I'm doing 5 days worth of patients in 3 days, and also including all the fallow time and clean time and everything else. So it's intensive. It's quite hectic. The idea between that was having one of those days off as committed to study days, which I am doing. But then there's also life laundry that gets in the way, and you know, stuff and things happen. But yeah, the frustration is that I don't have the whereas before, for instance, I might be able to stay a bit later, stay a bit earlier, just draw one patient out and say, oh, you know, perhaps we should have a look at this, and just use the opportunity to practice. I don't quite get that so much now, so I'll bring my scanner to work each of those 3 clinic days, and it might vary between not using it at all to using it maybe 3 or 4 times, but it does vary day to day because I need to keep my clinic going more than anything else. So that's kind of frustrating, but it is what it is at the moment, you know.
Cool.
So yeah.
Well done. Sounds like you're doing great. And what would you say what's been the best outcome for you for a patient as a result of your scanning, would you say? Any good examples?
I've got an example, which I think is probably not so much about my technical brilliance at scanning, but I think maybe alongside the other things that go with it. So I had a patient who he was 83, and during lockdown in April, he decided to trim his hedge with a power tool on a stepladder, you know, as you do when you're 83, and he fell off it, and he landed onto the post of his iron garden fence onto his side, and he only managed to break a couple of ribs. I was amazed. Anyway, he went to hospital, and when he got discharged, he found he was having a lot of pain and weight bearing and walking. And he fell on his right side, and obviously they're worried about his ribs and everything else. They didn't really look at the rest of him. He'd had a right knee replacement several years ago, many years ago, which wasn't really bothering him. It was only when he left hospital, was discharged, and started walking around, that he got a lot of pain whilst walking. There was a lot of heat. There was a lot of swelling. So obviously, I was concerned that he'd had an infection in there. But his GP did bloods, and there was no infection, so you know, he got sent away. But it was still getting the same sort of problems, getting worse, in fact. And so yes, he kept going back to his GP, who just kept trying to give him anti-inflammatories. And so when he mentioned it, and I thought, right, let's just have a look. I'm not an expert as to what a replacement, what the metalwork would look like, so I know it all varies and so on. But I just also wanted to see, you know, what it would look like. And I used the scanner and found, you know, a huge amount of fluid coming from the knee joint itself. So I wrote a referral letter with a couple of the images attached to it, and rather than him being sort of sent away from the GP all the time, he got a referral to the orthopedic consultant at the hospital. But he was just so grateful. You know, he said that they were just ignoring me. I know they're busy. I didn't want to bother them, but you know, I can't walk. My knee's swelling up. And he said, if it wasn't for you, I wouldn't. You know, I don't know what I've done. So that was nice. It was you know, being able to use that to help.
Yeah, great. Oh, really satisfying. Brilliant. Good stuff. That's great to hear. Thank you. Okay, great. Well, you can relax a little bit now because I've asked you. Unless anybody out there has any questions for Elaine, because I think that's a really good insight to hopefully a lot of you out there as to you know, getting on that road to scanning, and Elaine has got some, you know, can really share some good experiences there. So thank you, Elaine. I really appreciate you just taking time to share that with us, and thank you again for being a loyal It's Wednesday, it was Thursdays, wasn't it? Wednesdays and Thursdays throughout the summer and the autumn, and we'll look forward to seeing you in the new year as well.
So just a big thanks to the you three guys as well, because you've made it so accessible and brilliant, and you know, learning stuff from one source is one thing, but you know, every different scanner has a different approach, and tips that I've learned that I haven't learned on the course that I'm doing, you know, and I've been writing these nuggets down, you know, in my notes and so on, and it's just having the, you know, the different experiences of different people. So that's been, it's been brilliant. Brilliant. Thank you.
Brilliant. Well,
thank you, Elaine. Thanks for being with us and supporting us the whole time as well, and you know, being a staunch friend. Much appreciated, and best of luck with all your studies.
Thank you.
I'm sure you're going to be an awesome scanner once I'm sure you already are.
Thank you.
Great. Okay, right. Where's my man? Where's Sean? How you doing there, Sean?
I'm keeping good, Steve. How are you?
Very well, thanks, Sean. Yeah. And those of you who don't know Sean Savage from Belfast, and Sean, as I think I mentioned him a little bit earlier, didn't I? Sean was the first podiatrist in the UK to take on a Sonoscape scanner. And he's been a real support to Celtic SMR ever since. He's got there's a good crowd of you over there in Northern Ireland now with scanners, isn't there?
There is indeed. I think since I got mine, and I remember the day I got mine, it came in a nice box and opened it up, and the first thing, I think was you actually said, you know, put it on Facebook. And we have a little sort of society Facebook page, and I put an ultrasound scanner up and expecting, you know, a few sort of, my God, what's that thing? You know, who's this show off? I couldn't believe the response I got. People going, you're using ultrasound? That's amazing. That's fantastic. And even it was shared on the physiotherapy pages and stuff. So I instantly became the sort of scanning guy, even though I hadn't a bloody clue how to use the damn thing at that point. But it was amazing. I mean, Gareth and Claire and Suzanne instantly said, you know, bring it up to the clinic. Let's see what we can do with this. And I spent, I suppose, the first few weeks scanning my wife, the kids, everybody. Anyone had come in, I scanned, and I was busy looking through YouTube videos and just basically everything, looking through my notes. And eventually those white clouds started to make sense. And I was able to identify structures and things, you know. So it's been amazing. That was what it's coming up. I think it'll be 2.5 years since I got my scanner now, so it's almost becoming redundant. It's almost like one of those things that have floated up from a Titanic. It's that old, you know. But I got the E2 and I still love it. But I mean, one thing I've noticed sitting with Abid and stuff on a Monday night, I've got a real scanner envy now when I see some of these amazing scanners that these guys are using, you know. But maybe in time, have a chat with my wife, Euro millions come up, I might go out and buy myself the biggest scanner of all time, you know. But really enjoying it. It's been amazing. It's changed my practice. It's changed everything about what I'm doing. So I really enjoying it, and I love learning from these guys. Abid, I've nipped in and out. I've seen Adrian. It's just amazing watching these guys, and you know, chatting to guys online and stuff here. It's amazing. You know, that there's a good group of people that are like myself, keen to learn. And I mean, every day is a school day, and I just love all this. This is fabulous. It's COVID has been bad for everybody, but I think it's been amazing too, where we've just become, everyone's got so close, and there's lots of CPD, and it's the only golden cloud and COVID, all this sort of stuff. It's been amazing.
Sure. Yeah, it's a good point actually.
Yeah.
I think, you know, from someone from a commercial, my job is sales. You know, if a year ago I said to people, "Hey, I got this great idea, we're all going to come online and we're going to give you some training," everyone would have said, "No, can't we? Don't travel? Don't we come to you? Can't you come to us?" And that would have been the attitude, wouldn't it? But now we get it now. We don't have to run around like fools around.
Absolutely.
Clog up motorways just to be on a course. So that is interesting actually. So that's quite a good perspective. You've got a good crowd of you guys over there that all support each other. You've kind of started this whole buddy idea anyway, you guys, haven't you, with Claire?
Yeah, we did. So it's been, since I got my scanner, as I say, there's other guys then have bought scanners, and I've sort of started a bit of a scanning revolution over in Northern Ireland. And even Emily now getting her scanner in Southern Ireland, she started a huge revolution down there.
Yeah, that's right.
So everyone now, hopefully, but I mean, listen, I think it's amazing. And I used to be involved sort of in academics. I used to lecture in the University of Ulster. And so we'd still have a few sort of associate friends and stuff there. But one thing that I heard about a year back was that the undergrad physiotherapy is now going to be introducing diagnostic ultrasound into their program. And I spoke to the head of school there, who's a good friend of mine, Raymond, and said, Raymond, pediatrics are going to be left behind. I mean, we've got to start doing ultrasonography. We have to introduce it into the undergrad because physiotherapy are going to do it, and we're not going to be the foot specialists anymore. These guys are going to take. So they've now started to look into that, and they're now sort of trying to get a program involved. But apart from that, even just the local pods and things, I'm advising them, listen, guys, this is something we got to get into. You know, we're going to lose this. We've got to start being able to do, we call ourselves food specialists. We're not. We're the lowest of the low in terms of medicine here. So we got to start showing ourselves to our other, you know, the physios, the docs, the orthopedics that you know, we can do this. And I would work quite well with a few orthopedic surgeons. I can't believe the support they're giving me in using ultrasound. You know, they've been brilliant. I've been mentored by one of the top MSK radiologists in Northern Ireland, Noel Napier. He's been fabulous, so supportive, and you know, he allows me to sit in his private clinics, his NHS clinics. And what's great is what I find: the less you know, the more he questions you. But the more you know, he doesn't question you. So I think that's quite good. So he's not questioning me as much now. So I must be getting
that's
there.
That's a good sign. Yeah,
you know, it's a good sign. One of the others, his registrar said to me, if he asks you questions, it means you're stupid. And he'll want to prove you stupid. So he's not asking me as much now. So I must be getting on okay there. But yeah, it's amazing. And I just hope that, you know, with the passion and stuff that I have, and it's going to spread out, and other people are going to get scanners, because I think it's the way to go. It has to be the way to go. You know, it's
interesting you mentioned the students. I was invited on to a webinar not so long ago, talking to some students, and you know, there are scanners in universities, but they're typically used to train anatomy, to teach anatomy. I would say they're not used in clinic, you know, to actually treat on patients. So I was saying to them, Hester, the technician, can you use it at the end of clinic? You know, year 3 students, I'm particularly aiming this at, you know, but not exclusive to just year 3. Use a scanner, scan each other, have a play, use it, that skill with you out into the big world, you know, kind of thing. And one or two, it seemed to, you know, got a few nods of approval from one or two, whether they listen to me, I don't know. But you know, that was my point of view, was, you know, get scanning, you know, try it, do it, and as I say, take it to the party when you're going out looking for a job. So it's interesting you should mention the students. That's my little bit of experience and my advice on that.
Yeah, it would be great if it was introduced in the undergrad level for pediatrists, you know, give them that basic training first, and then when they come out, they can do their postgrad. I mean, the first time I saw it, when I did the QMUL sports med course in London.
Okay, yeah.
And
is that with Trevor and Nat?
Yeah, with Nat and Trevor and Otto Chan, we mentioned the other night. And, you know, the very first day of the sports med thing, the first thing we did was be introducing the ultrasound. And I walked in going, I haven't a clue. And Otto Chan instantly just started putting up scans of, it was actually a shoulder, and was going around the room asking people what could they identify, bone, cartilage, whatever. And quite quickly I realized, you know, if you're going to be involved in sports or MSK, you've got to be doing ultrasonography. You have to be doing it. And it's something that I never really thought. I thought I was going to go and learn how to do nice little manipulations and nice little straps and stuff like this. That was secondary. I mean, it was ultrasound. There was such an emphasis on that. So right from the word go, and we practiced, we had lots of scanners and everyone, I mean, every day we were practicing, and it was amazing. And when I qualified, then that was the first thing my wife was going, right, are we going to Florida for the summer? And I'm going, actually, I think I'm going to buy an ultrasound. So that didn't go down too well. So we bought an ultrasound, and I qualified, I think it was the June, graduated July, and I think I bought it in September, something like that. So, and I remember Nat saying to me, you know, when just do your ultrasound immediately, keep practicing it, keep practicing, keep looking at normal, you'll eventually see what abnormal looks like. And he was so right. So that's where I became sort of introduced.
Here's a question for you then, and it might help. Anna who's asked a question on chat there. Sorry, I've not got to that question yet, and I might have missed one or two other questions, guys. But so, and Elaine, we've got a good conversation going with regards to the future proof. You've had the E2 now for a couple of years, from learning from scratch. You know, you from when you got it. 2.5 years later on, obviously doing a lot of work with the scanner. Have you know, this whole future proof thing? Have you outgrown your E2?
Me?
You an X5 next month?
I'd love to get one. I really would.
But I suppose, serious question, I suppose that sounded like I was selling you. But the serious question is, that E2's standing the test of time, I suppose, is it?
Oh, absolutely. I mean, it's great. We get it serviced and it's fabulous. And I use it every day with every patient. I scan everybody. If they're, no matter what condition they're in. I mean, I do a lot of MSK stuff, so I'm probably using it more for ankles, for everything. I scan everybody with the scanners. It's just become part of my assessment program. So yeah, I'm using it. It's getting its use.
And it's proven.
Absolutely great, absolutely great. And I'm still learning things it can do 2.5 years down the line.
Yeah, of course.
God, I didn't realize it could do that, you know. So, and I've learned so much from Abby on a Monday night. I'm watching, going, good God, so you actually can do that? You twiddle that wee knob there, and that does that, you know. So it's great. It's great, you know.
Brilliant. Thanks, Sean. Really appreciate your time there, and it's great to hear. Really enthusiastic. I'm pretty certain that's inspired 1 or 2 people out there. So thank you. That's
no problem. Thank you.
So yeah, and more to do in the new year. We're coming over to you in the new year for a workshop you're putting on, and I think I spotted early on the chat you've stuck your hand in the air to be involved with the buddy system that we.
Well, the course. The course we decided to do a course. Opened it up to 20 people. It was sold out in a 2 days. We couldn't believe it. We were expecting, you know, if we get 5 or 6 people cover costs here, we have a waiting list now. We couldn't believe the amount of people that want to get involved in it. NHS and private practitioners. So it was sold out, and we've now 21 people on board. We've got Abid and yourself, Steve. Can't wait. And the facility we're doing it in is a local hospital, but it's been running courses throughout COVID. So they have these little COVID bubble things and stuff. So they said no matter how much of a lockdown there is, it will still happen. So
awesome.
They're you know, but really looking forward to it. But we couldn't believe. I mean, we're already thinking of running a second one down the year. You know. So there's a lot of interest over here, which is great.
That's great stuff. Keep up the good work. It's brilliant. Well done, Sean. You're an inspiration. You really are. And thank you again for that. That's brilliant.
Thank you.
Abid and Adrian, you still with me?
Indeed.
Brilliant. I think I'm just going to check if I've got any questions. I think Mark. Hi, Mark. Good afternoon. Good evening, Mark. That is Mark Barton. Another Sonoscape user.
Can you hear me?
Hiya, Mark. How are you?
Yeah, I'm good. Can you hear me?
Loud and clear, my old buddy. Yeah, you had a question. You got a question on here. I'll ask it for you. Can I ask Abid and Adrian how they would advise us to use ultrasound in clinic when you are still training? Abid and Adrian?
Sorry, you went a bit crackly there, Steve. Can you just repeat that, please?
Yeah, of course. Could you,
do you want me to ask it?
You're all right. I've got this.
Yeah, he's just right there. You could just...
Abid and Adrian, how would you advise to use the ultrasound in clinic when still training?
Yeah, I would just say don't be shy. You know, just make it clear to the patient. You know, you don't know what you're doing quite just yet. Yeah, you just be clear and upfront. You know, I found, you know, I just asked the patient and just got their consent. You know, verbal is enough. Look, I'm not diagnosing you. I'm just picking up this thing and having a little look inside to see what I can see. And you know, that's as complicated as it gets. I'm in training, so if you don't mind, you know, and I guarantee you won't have even one person give you any negative feedback or chuck you away. So I know the difficulty probably is just the time thing, but even if you're just picking it up to look at just one thing, you know, on each person, just look at the visualizing the big toe joint, because every single person is going to look so anatomically different, and that is the interesting thing with it. So just pick it up and look at whatever's closest to look at. You know, it literally is a 2-3 minute thing, so you can squeeze it in. It's amazing what you can get in once you do try and make the time for it. It's just being conscious of just have it right next to you, have your jelly ready, and before you start whatever else you're going to do on your patient, just pick it up and say, look, I see you've got pain in this area. I'm not fully qualified yet, but I'm on my way. Would you mind if I have a little look? And you know, I think that's just get it in there. Get it in there. Don't be shy whatsoever. You won't get any negativity or feedback, bad feedback about it. And actually, they'll be really grateful, and they'll be really interested. And the neat thing I find with patients is actually, hang on a second, let me just turn the screen round. And yeah, this is what I'm looking at. So if you look here, this is the skin up here, yeah, and this is the soft tissue. Here's your tendon, and look, oh, I can move it at the same time. You know, and a couple of neat tricks that we've hopefully all picked up a bit of along the way, and they absolutely love it. They absolutely love it. You know, they like a bit of attention anyway. You know, and
that's interesting, you know, that Abid, because I was going to ask actually, and I think I've asked this over the weeks. Yeah, do you get patient involvement then?
Yeah, I always use it, but personally, I always use it to talk the patient through and clinically reason what I'm doing at the same time. I'm showing the patient what's going on and where we are. You know, what I usually say to a patient, this is the process I usually take. Okay, so get the patient and get them involved. Okay, so I'm going to do a scan for you. I'm going to go quiet for a couple of minutes. I'm not going to say much. Because I'm going to concentrate on this, so excuse me for that. But once I'm done, I'm going to try and flick the picture screen around and try and talk you through what I'm looking at. And it's great. You know, it gets the patient on side with you as well. You know, they have more confidence in you. Look, this guy's learning to scan. This is, you know, scanning is a big thing. You know, go to a private hospital and have an ultrasound scan. You know, Adrian will confirm. You're talking about 300 quid's worth of investigations that are traditionally done by consultant radiologists. Yeah, so you know, ultrasound scan is a big skill to learn. You know, be proud of the fact that you've got a machine and that you're doing it, because picking it up is one thing, getting good at it is another thing. It's a long process. You know, and I always say to my patients, you know, and nobody's grumbled at me charging. You know, I always without a report, I'll charge anything between £70 and £100. Yeah, just for the fact I'm picking up the scanner and I'm having a little look inside. Yeah, and for me, it's aiding. If you just think of it, it's aiding your clinical diagnosis. I've never had anybody grumble about that. No. You know, at the end of the day, it's a scan. Where else are you going to go to get a scan? You know, an X-ray at a private hospital is a couple £100. You know, an ultrasound is, an MRI is. You know, you expect to pay money. So if you're just charging a little bit extra, I just say to them clearly, look, you know, consultation is this much. If you want me to scan it, you know, yeah, that's fine. I can, but I've got to charge you a bit extra for it. You know, it's a scan at the end of the day. I've never had anyone say no. You know, they're actually really keen and interested and inspired, and you know, it makes you look good. It makes you look good. It doesn't matter that you're not qualified yet, and you know, maybe don't quite know, but the fact that you're trying and you're looking, and they can see you concentrating right in front of their eyes, you know, and really trying to figure things out. I think it's nothing but positives in it. So go for it. Get your machine and go for it on every single person you can. Because that's the value in it, really. You know, that it really truly is about how much hands-on practical time you put into it, and like any other skill, you know, it's just the amount of time that goes in is exactly what you get back out of it.
Yeah, because one of the things, can you hear me, guys?
Yeah, go ahead.
Sorry, because my headphones are blowing up a bit. Because I'm doing the case course down at Bournemouth, and I've done all the essays. I've passed the first bit, and I'm just sort of getting up to my exam. but because of COVID, I haven't been able to do any mentoring, and mentoring is an impossible thing to do anyway at the moment, especially if you're a pod.
Yeah.
So I bought a sonoscope from a private practice. I use a different scanner in the NHS, so there's a difference between the two. But I knew that using the scanner privately, I was going to have issues with patients, you know, charging them and telling them I'm training. People don't want to pay if you're training, basically. Do you know what I mean?
No.
It's a really difficult one.
Yeah, I think if you're not confident enough to be, adding it into your treatment package and pricing it individually, and as a function of your clinic, that we scan and we know what we're doing, and therefore that's why we charge. I think that's a different issue. It's about your confidence, isn't it? When do you feel comfortable at the point where you're happy to charge somebody for your services? And that's an individual thing.
I charge them because I use it for injections, so I charge accordingly for that.
Yeah, absolutely.
But the diagnostic side, obviously, we're kind of stumped a little bit.
Yeah, probably once you've got your certificate and you've got that qualification under your belt, that's probably the time to start charging for the.
It's an interesting one. I get asked a lot about the return on investment on the equipment, and I have to say, when we sell as lasers as well, and I can make a really good, easy return on investment argument, if you want, for a better phrase, story on the laser. But the scanners, I don't think it's difficult to put a tangible return on investment. I'm going to scan you, I'm going to charge you, it costs me X a month, I'm going to charge you.
But the fact that it enhances your practice and you can probably offer more to that patient, 100%. I mean, a bit like, just to take the laser example from Steve there, through this whole COVID thing, I got myself one of those laser things, and actually those patients that I might have otherwise turned away or said, you know what, I can give you this, and that's it, and they maybe didn't like it or didn't like it, and I didn't have to refer them off to physio or orthopedics or anywhere else. I had options to treat them with. And a bit like your ultrasound, once you've got it and you can look and go, well, actually, that's for an injection probably. I think I can do that, or it's not that bad. You'll be all right with some physio manipulation on that. So it's not always the fact that that's a separate thing. It enhances what you can offer, and it helps to hone your clinical skills at the same time. So you've got more options once you've got ultrasound. You can tell them, look, we can kind of diagnose it. You don't have to go anywhere else. You don't have to go back to your GP. I don't know what I'm doing. I don't have to refer or recommend that you need a scan or X-ray, because I can kind of do it here. So I think it opens your options up. So it's not always just about charging for the scan itself. It's the fact that you've opened your practice up to be able to offer more services and treatments off the back of the ultrasound scan to patients that you normally would have had to refer elsewhere or not been able to help at all.
You're potentially getting your diagnosis sooner, and you're getting it right sooner, so the treatment plan is going to be better sooner. That, as I say, you can't put a tangible return on investment on that, but by Christ, you can improve your clinical.
I'll give you one example of plantar fasciitis, for example. So you've got your patient in, and you've got it's plantar fascia. Okay, well, it's measuring about 5 mil, 6 mil. So yeah, you've got chronic plantar fasciitis, but it's not chronic and severe. So maybe we can go down the conservative route with you, and it should work, and it could blah, blah, blah. On the other hand, you see one at about 10 mil, and it's just florid and inflamed and awful looking, and you just know no matter what bloody insult you put under that heel, it's not going to do absolutely frig all really. So you're going to say to them, do you know what? I could give you an injection. That's going to work much better than you trying this and trying that for months and months and months. Yeah. And I've been able to give you that, one-stop shop advice and the right treatment at the right point at the right time, to resolve your problem. So it really does enhance what you can do. And there's many instances now, since I can give you no end of examples where, because of what I've seen on the ultrasound, I've decided not to even bother with orthotic therapy or intervention, because I know it's not, it's just a chronic inflamed joint. There's no bloody point, trying all sorts of different gadgets and whatnot. You might as well just stick some steroid in it, because that's going to reduce that inflammation and get rid of the pain. And, that only became apparent because you were scanning, not, may not have been otherwise. So, sorry, I'm waffling again.
You're good. And it's gone 9, and I've got a load of questions here. I suspect we're not going to get through all of them. I've got a couple of questions that have come in. We've got bit of info here from Katrina. Hi, Katrina. Katrina's been a regular contributor over the weeks with us. Upcoming NI pod, Northern Ireland pod, does that mean? Yep. In ultrasound once qualified, currently doing my dissertation on use of ultrasound for peripheral arterial disease diagnosis. There you are. Well, she's one of the family now. So anybody got any advice you can give her on that? Get in touch. We're here to help Katrina. So thanks for coming along. Hope you've got something out of these evenings as well. And take that with you. Get the use of. I take it that is you at the Northern Ireland pod. Therefore, you're at the Ulster Uni, as Sean mentioned earlier. So get use of their scanner. Have a play. Use it. What else have we got? Amanda. Hi, Amanda. Any pods in the five of Scotland? I know my geography in Scotland's pretty rubbish, but Kieran Canny's your man, or Paul McMullen. Don't know exactly where they are, but
I was up in Stirling not last year, the year before, when we were training a group of pods up there on ultrasound. So I'll have a little look into that and see if I know anybody also that's carried it on.
I can find that out for you, man. But if Kieran Canny and Paul McMullen are near you, get in touch with those guys. Good guys. And they've got sonoscope scanners. They're not only good guys, they're clever guys. Okay, what else we got? Right, Zoe, would like to ask about image-guided injection, please. Do you want to come on, Zoe?
Hello.
Zoe,
Can you hear me okay? Yeah.
Good. Nice to see you.
Yeah, you too. Thanks for inviting me. So basically, I'm an MSK podiatrist primarily up in the Lake District. And I've just got my I've got two machines, thanks to Steve. I've got an X2. Is it an X2?
E2.
E2. Mixed up. E2. And I've had an E1 prior to that, which is what I've been using for about 3 weeks. So that's been brilliant. And I've been scanning everyone. I literally, one that sits in the chair, I'm like, we're just going to have a look at this. I said I am in training, so can I just investigate? But I already offer steroid injections, so I've done my steroid injection training through podiatric surgery, really. But in terms of image guided, I'm confident in, for example, doing an image guided injection maybe in the forefoot. I've done a couple of those before, but I'm aware there's cadaver courses that you can do on image guided. I've not done the course yet, but because I've got the ultrasound, can I do image guided, or would you advise, getting your certification on courses first, really?
But personally, I think it's a practical skill. You're not going to learn it out of a textbook type of scenario. It's just practice, and it's getting your eye with the machine and then on the patient at the same time, and then trying to make sure your needle and probe is in the right position. So I think it's more pick what you can, chicken legs and all that sort of stuff, and have a little play. And then at some point you're going to have to go live with it and just try it on somebody. So the default always is what I did. The default really was the fact that if I wasn't, because it is a bloody fiddle, no matter what, it's a real skill to pick up. So if I wasn't really confident that I was getting the needle where it was supposed to go, at the very least, I was able to anatomically verify where I should have been.
Yeah.
And the thing is, it's not a deep, it's not generally deep structures. They're generally superficial structures that you're going into. So worst case scenario, if you're just like, you're trying and you're just not quite doing it, well, at least, do you remember I was showing that technique where you just use the probe and then you just use your finger under and you kind of know where you've landmarked, then make your little mark and then just go in. So, once you kind of got the hang of it, it's fine. So I'd recommend just try and do whatever injections you're doing. And the way really to keep it safe is to just use the local, infiltration initially, and you'll see, if you're in the right place or not. And then you got to pick your guided injections as well. Some are probably nice and easy and straightforward and not too difficult to do, and others are just tricky and complicated. So it's just up to you and your personal skill level and confidence about how far you do or don't go with it. I couldn't say that I do all my injections guided at all. Sometimes it's just not worth the hassle and the extra time, and particularly if I'm doing an NHS list, you know, I'm fairly confident I know my anatomical landmarking, so I'll just kind of whack it in there. And
that's the thing. Like I've not really used it that much. I mean, I'll get an X-ray if I'm doing a first MTP, for example, just to confirm diagnosis, and that's just been advised really from a point of view of your notes and that patient that's coming in. But like, into metatarsal lesions, when you're looking at bursa and you're looking at neuroma, I think, gold standard, I would prefer those to be image guided. And obviously I'm not confident enough yet. I've only just got going with it really, but I have been advised by a couple of people that offer them, that there are a couple of the cadaver courses which are very well recognised for education on a standpoint of image guided. So I just thought
I think it'd be worth you doing it, because they will teach you there's two different techniques really. You've got the in plane and the out of plane, and you need to remember that with the in plane, that your beam is only 1 millimeter thick. So it's not the width of your probe, it's the width of your beam, and you've got to get that needle in that beam. So for your in plane, but with your out of plane, you're not going to see a needle, you're seeing a dot. So you've got to know the end of your dot, and the trick is you've got to go off your needle, advance your needle, off your needle, advance your needle, because you're always going to be seeing a dot no matter where you are on that needle shaft. So they'll teach you those two techniques. So it's worth doing. But the cadaver courses, obviously there's not much fluid, if you like, within the cadaver, so it's all really thin looking. So it can be really difficult to interpret the anatomy because it's all squashed down. But it is worth doing.
Zoe, can I
sometimes you can't see where your needle placement is at all, no matter how hard you bloody try and see. So the other way is to just start to infiltrate your local into the area. You'll see the tissues welling up, and you'll see the change, going on.
A good way of perfecting that sort of under-eye coordination, I found, and I found this on a paper on the internet, was if you get some of that vegetarian jelly stuff that people eat. What's tofu? Get a block of tofu, it's cost peanuts, 70p or something, and I stuck into it. I put some photographs on Facebook somewhere, you might see them, and I stuck various different bits of like thin thread or wooden. I think a couple of chopsticks.
You got some skewers, didn't you? I think.
Yeah, skewer. I think I used some earbuds and things, and basically you just use there's on the E2, I think it is on the X3. There's a needle guiding angle which you can on to give you some idea of what angle you're at, and you can stick it into the tofu all night. It doesn't complain, it doesn't scream or anything, and you can stick it in there, and you can get some good results, really good results, and eventually you'll find in plane and out of plane you can stick it in, and as soon as you see the dot, bang, you can inject, and within a couple of hours of practicing with it, you could spend £2 to get 2 blocks of tofu, and you'll get it. You'll get the angle, and you will get the depth. It's the depth is the thing that you find it difficult to judge initially, and it's a really good technique. I didn't make this up. There's a paper on it that a guy showed, as a cheap way of perfecting it before you do the cadaver course, maybe, so you look good when you do the course.
You can overthink it. You just got to get on and do it. So if Steve and Adrian are in agreement, perhaps we can the next program we do, we can just play around and show how we do it, kind of thing. Yeah, we'll get some tofu and chicken legs in. We'll lay them out here, and we'll just go for it and see what happens.
Sean is going to jump into something.
Just quickly, Zoe, I did the cadaver course in the QMUL, but I think they also offer that on a day basis as well. With Nat and Trevor, it's really good actually. What I did as well, I then sort of contacted a local MSK radiologist and just asked her to sit in and watched a lot of him doing it, and it was good fun, so it's good contact as well. I
found a physio locally. I think the day that I got that machine, I was like, right, I need to make some friends and go and sit in and try and learn as much as possible. So his name's Graham Dawson. I don't know whether any of you have heard of him now. So he's based up in Cumbria, but I'm going to go and sit in with him in January, and just sit in on a clinic and try and do that as much as possible, really.
Yeah.
So I know Graham. He's on my course. He's a smashing bloke. He's so lovely.
He's lovely.
Yeah, and he's very good. I think he does it all the time. I think he's very good. Yeah,
That's what I was worried about, the mentoring. When you look at these courses, it's like everyone goes on, the mentoring's really hard, you'll never find a mentor, blah, blah. But, sometimes you just have to reach out and say, we've all been in the same position. Can I come and bother you for the afternoon?
Well, I can't imagine he'd say no. He's very approachable.
Yeah.
So, yeah, good for you. Yeah.
Brilliant. Thanks for the question.
Thank you. Thanks for
the
that.
input, everybody there. Thank you, Martin. Good idea there. Before you go on a course, go on an expensive course. There is ways of practicing at home. So some good tips there. Thank you, Elaine. That's brilliant. Lots here. I'm conscious of the time. You might all start disappearing. I'll just be talking to myself in a minute, but that's just a typical day for me. Let's have a look. Actually, Sam's asked a question. She's looking to see if she could pop into any local potential clinics for visits, so she could do some kind of observing. Now, Sam's in the Midlands area. I don't think anybody on here is from the Midlands, but let me put my thinking cap on for you, Sam. I'm sure I know somebody. Well, apart from Abby, of course. Sorry.
Yeah, I'm here.
And Adrian. Actually, you got two of the best in the Midlands. Actually, no, they're amateurs. They're no good to you. You don't want to. You have to go further afield to find some.
Don't come in.
Sorry, Adrian. I was looking at the users rather than the trainers. But no, they're no good, Sam. You don't want to. You'll learn.
Definitely not.
Those two. You are spoiled to the Midlands. In other words, Sam, you've got Adrian and Abid, so you've got their contact details. I know you spoke to them before through this. Get in touch with them, because you know how helpful they are. If they can help you, we will. You know that. So Coventry.
Yeah, absolutely. Get in touch. We'll figure something out, I'm sure.
Yeah. Sorry, my geography's gone with me again. Alan's got to go now, but Alan's been a regular contributor to our show. So if I'm not too late to say thank you and cheerio to Alan, thank you.
Thanks, Alan.
Now, Chris has put something on here which I haven't read first, so I hope you haven't sworn in here, Chris, because I'm just going to read it here. Return on investment for scanner. I scan 80% of patients. I tell them I am not at a level to formally report, diagnose, but scanning is an integral part of assessing and assisting correct clinical impression and treatments. They love being scanned, and the enhanced reputation and better targeting of care pays for itself in word of mouth. Couldn't have put it better myself. Brilliant. That's great to hear. Show them the anatomy, movements test as it happens, and compliance on their self-care is usually much higher. Reuses, we have excellent shockwave results. Shockwave, what's that? Not to swear. Shockwave. Can't go anywhere without somebody making a wave. We're
I'm
friends.
I'm going now. Goodbye.
I've shown the anatomy. Where did I get to? We use the results for calcification, because we can see that this is the actual diagnosis via the scan. So we can put the something or other wave exactly where it is needed using the image to pre-look. Do you know what? All joking aside, thank you, Chris. That's really good input. I don't know if you guys can see the chat. I don't know if I've read out something you can all read, but thank you, Chris. That's great input. Thank you. Shockwave, actually, all joking aside. And for those of you who don't know what the joke is there, we do laser therapy and it's better. Just okay, you don't hurt anybody, right? So but that's one for my Friday webinar. But anyway, so shockwave. There's more, hearing more and more when I talk to people about scanning, that the really, for gold standard shockwave, that you really should be scanning first. Am I making that up, or did I dream that, hoping it, or is that the case? What's the thoughts?
No, I'd agree. I started shockwaving a couple of years ago now, and I realised very early on that it could cause some damage if you're not actually, you don't know what you're shockwaving, and particularly with things like tendon Achilles tendinopathies and stuff like that. And so quite soon, unfortunately, after I bought the Shockwave, I realized I probably had to get a scanner. And that's exactly why I got it, because I needed to prove to myself that I wasn't causing more damage than was necessary. So absolutely, I think unless you're very good at MSK and you're using a Shockwave machine, then I think you really do need to scan first, particularly with tendon Achilles things. Yeah, that's my opinion, for what it's worth.
So you got two choices, guys.
Having done
Get a
quite a lot
laser,
now.
you don't have to buy a scanner. Buy Shockwave, you don't buy a scanner. Either way, you got to talk to Steve. Thank you, Martin. Adrian, anything to add on that?
I do use a laser as well. And,
I know you do. Yeah,
but they don't work.
I put you on mute. You're outstage, you're welcome. Adrian, Abid, anything to add to that?
Yeah, oh, absolutely. Just scanning is just the best for everything. You know, it's 2021 nearly. You know, there's no point guessing. We shouldn't be guessing what we're doing. You know, we've got the technology available. It's readily available. It's affordable. You know, I think we're doing a great disservice if we're not, advancing and developing our practice enough to be able to accurately know what we're doing. I think gone are the days where you just go and have treatment just for the sake of it. You know, I remember I knew. Not pointing at professions or anything, but I know one example I can give you is a physiotherapist doing acupuncture on a guy's shoulder, 30 sessions before she said, you know, I don't think this is going to get better. And all along, you know, there was a torn tendon there. So the fact was that it was never going to improve no matter what. So that poor chap has gone through all that, you know, of having needles stuck in him, you know, and she stuck needles. I saw it was like a pin cushion. You know, and the fact was he was never going to get that function back until he'd had that repaired. You know, so you know that's wrong in my book. You know, to start treating something without knowing what you're doing and just for the sake of it. Oh well, let's just see what happens. I think those days are long gone. I don't think that's appropriate anymore now in this day and age. You know, and surely for the future generations, you know, we shouldn't be doing that at all. We should just be like, yeah, okay, you got pain there, right? Let's put the scanner on, see what's causing it. Okay, well, it's this. So we can do this, and this, or you can do that, and that, and there you go. That's your options, and you know, it should be healthcare. You know, one-stop shop. You know, they've come to see you for your opinion. You know, you've backed it up with imaging as well, and your clinical assessment, and then you can give them the most accurate treatment you can possibly give them for the quickest resolution of the symptoms. And I think that's fundamental in the world of MSK, at least.
Brilliant, thank you. Great. I'm just keeping an eye on anything else coming in. I hate to miss questions and people think me rude. I think you all know me now. I'm not rude. I'm just a bit dim. From John, I didn't spot John was here. John Yeboah. Nice to see you, John. Very informative. Thanks, Happy. And Steve, I even get a thank you. Thank you, Alan. That's great. Well, what else have we got here? Anna asked said some questions earlier, and we've not got to those yet, but I will ask the questions on email and we'll reply to you. But Anna has made another regular contributor. Anna, I think diagnosis is just so important. That's what can set us apart. Well said. Quite agree. That's brilliant. It's interesting. You know, the whole thing, you know, my experience when I, like a bad penny, turned up to the podiatry world 3 years ago, having had a breakdown and went a bit doolally for a couple of years. When I came back and started talking to pods in particular, you know, I rocked up at various conferences with scanners, you know, there really was, you know, what are you doing here kind of attitude, and, you know, don't think we can do this. There's people like Martin, actually. I remember one of the first pods I talked to in Bournemouth nearly 3 years ago, that was encouraging to say, no, this is what pods should be doing. And we've heard those kind of stories tonight from the likes of Sean and Zoe and so on and so forth. They're the pods, and then of course there's Elaine from the osteopath world and so forth. So it's really interesting. You know, 3 years is a long time. This year's a long time. So that's really interesting. It's great that, you know, it's setting you apart. It's moving you guys on to another level.